Okay, all right. Hi, guys. Can everybody hear me?
Yes.
What? Okay, let's go ahead and get started. So my name is Ognjen Stevanovic. I'm one of the new associate physicians here at the PBO. Sports trained and mainly focus on hip preservation, labor repairs and hip pathology in a young adult, as well as complex knee. And so today, we'll kind of go over sort of a common topic young adult active population with these ACL tears. So a little bit of background. I was born in Serbia, or actually in Yugoslavia back then. Migrated, once the Civil War started, migrated to Belgrade. From there, I actually lived in France for a couple of years. I played basketball there. I lived in a town called Ognjen, which is just south of Paris. Fantastic year, lots of fun, pretty much zero responsibilities in life other than just to, put the ball through the hoop essentially. And then the year after that, I moved to the States, to Kansas. So, I was at a place like this, which was obviously not that interesting as France was. My training then took me to Lawrence, where University of Kansas was. I got both of my degrees there. I was a pharmacist before I was a physician, so I got my PharmD and MD there, and it was really, good 10 years that I was there, and a good place and a good school to attend. I went to Chicago after that. I was lucky enough to be selected as a resident for orthopedic surgery at Northwestern University. Got an excellent training there. Chicago is an amazing city. Had a lot of sports coverage experience. I worked with the Blackhawks pretty closely. Also, I got some early introduction to the NBA. We typically covered the combine as it would take place every year in Chicago. Also, I did work with the NCAA March Madness. This was the first year that I covered the tournament. The regionals were in Chicago, and we covered Sweet 16 and Elite Eight. My subsequent training took me to Denver, Colorado. I was at the Stedman Hawkins Clinic. We Again, a fantastic fellowship. I was very lucky to end up being there. And Colorado is an amazing state. I did a lot of skiing there, a lot of outdoor stuff, rock climbing, hiking, all that typical Colorado stuff. But also got a really good sports coverage. I mean, these are some of the teams that we regularly covered. Denver Broncos was the vast majority of my work there. Covering games and the training camp and all the physicals and so on. I did quite a bit of traveling with the Colorado Rockies and covered spring training in Scottsdale. With the Denver Nuggets, again, great year, won the title last year. Easier work compared to the Broncos because the basketball players don't really get hurt that often. But again, lots of fun. And then these are some of the other teams, the Colorado Rapids and the Avalanche and so on. These are some of the pictures from the training camp with the Broncos at the games. You see me next with a very angry face next to the Russell Wilson, who's at this point now they just got rid of him, unfortunately. But this was a good year. My other sports coverage includes U.S. ski and snowboarding team, and I'm still in the active physician pool there. That picture on the left was from the camp that we do for all the docs, where we do trauma simulations on the mountain, and it's a pretty good trauma course that we kind of teach and introduce new physicians to. And then on the right, it's again March Madness that I covered last year. I did a lot of operating there, a lot of good surgeries, had good mentors. It was a fantastic year for sure. This is the overview of my talk. We're going to start with anatomy and then kind of go through each of these points in subsequent slides. A little bit about anatomy. I mean, this is not that critical, but there's two bundles to the ACL, anteromedial and posterolateral. This is kind of what they look like arthroscopically. Although if I'm honest, you hardly ever see them this separated this well, where you can definitely see the two bundles. Usually the area is kind of covered with a synovium. The blood supply comes from middle genicular artery, and most of the best of the blood supply is actually on the femoral side, because there are other tributaries from this artery that supply that area. And the innervation is from the tibial nerve. There's some pain fibers there. However, there's a lot of proprioceptive type of input there, which is important, obviously. The two big osseous landmarks in the ACL is this lateral and condylar ridge, and that's also called the residence ridge. So you always want to be behind that when you're putting your ACL in. And then the bifurcate ridge separates the two bundles, and double reconstruction now is not very common. Dr. Freddie Fu from Pittsburgh, who's unfortunately passed away, but he's an absolute legend in the orthopedic world. He was the pioneer of reconstructing individual bundles. That hasn't been shown to give superior outcomes, but regardless, he was one of the guys that attempted to do that. The femoral footprint, it's mainly kind of all the way in the back of the knee, and this is kind of what we see. This is the position where it looks like operatively when we look at the scope. It's kind of deep, within the joint and then low as possible. The tibial footprint is as shown there. It's pretty close to the kind of lateral meniscus and intermeniscal ligament. As far as what it does, the ACL is obviously a stabilizer to that anterior translation. And so, but it does have a rotational component to its stability, as well as varus and valgus rotation. This is something that wasn't recognized in the past, and that was, oftentimes ignored with the techniques that people used to do. And I'll talk about that a little bit, why the rotational stability is important. Obviously, this is a very common injury. 400,000 ruptures in the U.S. alone, and then vast majority of them happen during sports. And usually this is in cutting type of sports, jumping sports such as basketball, soccer, football, and then skiing is not. It's usually more like sport related. And then the injuries have increased over the past 2 decades, not because people are weaker or whatnot. I think people are just more active, and there's a lot more youth sports and things like that. So the risk factors is obviously young active people, pivoting type of sports. The females are at a higher risk, and this is well known and described in the literature. And the reasons, some of the reasons is just the landing mechanics are a little bit different in females. The anatomy is a little bit different. The Q angles are a little bit higher. They have somewhat more quad dominant mechanics and a little bit of a weaker hamstrings, which also put them at the risk. There's some hormonal influences, and it's arguable whether they have a little bit more joint laxity compared to the male counterparts. The playing surface, there is some evidence that the ACL injury is higher on the turf than on grass, and that's why most NFL teams are trying to switch away from the turf. And then the other risk is a previously torn ACL. The mechanism is usually a pivoting injury. There's a buckle. The knee buckles. Oftentimes patients hear a pop. Typically, within 24 to 48 hours, you have pretty profound swelling. Typically you have to have near full extension for this to happen. So unless you're a high level, bring a skiing into this discussion. Skiing is not that high of a risk for an ACL tear, unless obviously you're at a high level skier, because your knees are a little bit more bent when you're skiing. So it's not as common as people think. I think people that tear their ACLs are usually very, very high level skiers that do moguls, they do backcountry, whatnot, or elementary skiers that don't have proper stance. Physical exam, obviously, you want to look at both knees. You should have a pretty big effusion if it's an acute injury. The range of motion, is important. The ligamentous exam, I typically don't do anterior drawer. Lockman is my go-to way of doing it. And then a pivot shift is very difficult to do in clinic because the patients often guard, and this is something that I do before every surgery to see, what is that rotational stability that the patient has, and is it affected? So, and then obviously a neurovascular exam. The way to diagnose is obviously you got to get the MRI, but there's a high level of suspicion if somebody does have a positive pivot and then a positive Lockman. There's some pathognomonic features on the X-ray. This guy here, you can see this little bone fleck on the side. So to an untrained eye, this would look like nothing. And however, this is known as a Sagand fragment. And so there's in that area, there's it is thought that the insertion of the anterolateral ligament, which is important in stabilizing the knee. And so when the ACL pops, it kind of takes the anterolateral ligament as well and pulls it away. You can kind of, obviously here in the MRI, you can see a tearing off of the proximal aspect in the femoral insertion. And then you oftentimes see this bone bruising. So if you can think about it, the femur and the tibia, because of the anterior translation, the tibia will go this way into the front and the femur will go into the back, and then these two surfaces touch. This is also why, probably in my opinion, this is what induces that arthritis and this initial injury to the cartilage. There's some triggering event with that impact that impairs the blood supply and triggers a cascade where it would lead to arthritis. You have other injuries quite often in this setting up to 50%, whether it's the other cruciate or collateral ligaments, and then a meniscus tear. Obviously, lateral is a little bit more common with this because you have that valgus load, and then oftentimes there is a cartilage damage because of that impact and that initial event with instability. Why would you reconstruct the ACL? In my opinion, why would you not? I mean, if you are a person that does any type of activity that involves dynamic movements, I think you do need that. Now, if you don't reconstruct it, obviously, and it's definitely an option. However, there is a risk of perpetuating other pathology within the knee with the cartilage damage as well as the meniscus. There has been studies in the past that looked at this, where this first study, they looked at 1,000 patients, and again, they non-operatively treated patients do have a higher rate of subsequent meniscus tears, arthritis, and a progression to total knee. And that is, if you continue to do the sports and activities where you need that stability, then that would induce that continuous and perpetual trauma. So typically people that don't need ACL surgery are people that are obviously they have advanced arthritis, that don't feel sensation of instability, that have any sort of straight line activities that don't involve quick change of direction and jumping type of mechanics. And then other patients, you're not going to operate on somebody who cannot go through the rehab, because the rehab is actually, in my opinion, more important than the surgery itself. So everybody needs surgery, I think, to have a stable knee. Clearly young patients and people with other injuries within the knee. Otherwise, you may be, putting these patients at, risk for early arthritis and then arthroplasty later. The goal of surgery is not to prevent arthritis. The goal of surgery is to stabilize the knee. And so to stabilize the knee and have the patient return to their usual activities. The success rates are pretty good. However, there are failures, just like with any surgery. And the most common is the recurrent instability or inappropriate tensioning or failure of the graft, and stiffness as well. And so when it comes to stiffness, the preoperative rehab is very important. You really want to have full range of motion before you go into the surgery to make sure that the patient will have an optimal outcome after surgery. So you want to set them up for success. It's completely okay to wait and to regain the quad strength and to regain the range of motion before undertaking surgery, because the rehab is long. There is inevitably quad atrophy, as you can see in this picture there. And you really want to avoid that arthrofibrosis, because that is a difficult problem to manage once it sets in. The effect of prehab is outlined in this paper here. This is from AJSM in 2019, and they looked at patients that underwent BTB reconstruction. They split them in patients that did exercise and that they did nothing. And so 6 weeks of prehab led to a better function overall with multiple patient-related outcomes. So the other thing to think about when it comes to these is the graft choice. There's four options. There's the patellar tendon, so bone, patellar tendon, bone. There's the hamstring graft, and there's a quad tendon graft. And there's two options with the all tissue or quad tendon and a bone block, and then allograft tendon. So all of these are pretty strong, biomechanically, and they're stronger than the native ACL. Who should you do an allograft for? For me personally, in my practice, it's very much patient dependent, but typically if somebody is over 40 or 45, I would I would suggest that we do an allograft, and I use a hamstring allograft in my practice. I think anybody younger than that, I don't think the outcomes are appropriate. I think the rate of failure is high. Definitely not in teenagers and young adults, because those are unacceptably high rates of failure. And you can see that on this chart. If we compare, a 20-year-old has nearly 20% risk of failure with an allograft. So that's unacceptable to me. So BTB graft is a very good graft. We have the most data on it. We've looked at it. We've used it forever, and I think it's a very good graft. It has you have the bone-to-bone healing, which is the strongest healing that you can have, in the body, and it has a rigid fixation. When you compare it to the hamstring, it's pretty similar with the outcomes. However, there is some disadvantage to the BTB, because there's a known anterior knee pain that happens with this, because you cut out that bone as you take the tendon with it. There's no difference in laxity or graft failure between those two grafts. And again, this just redemonstrates there's kneeling pain, pressure pain, and then some arthritis as well in BTB. If you kind of further dig into this AJSM meta-analysis from 2017 does show that there's superior stability compared to the hamstring, but again, there are stat disadvantages. So each of these grafts have pros and cons, and for me, it's a discussion with the patient, and what they do and what they want is something that select eventually. As far as the high school and college athletes, this is a Moon study or Moon cohort that they looked at in 2020. They had a 6-year follow-up for the majority of the patients. 64% had a BTB and 36% had a hamstring. They found that there's a high incidence in both ACL revisions. However, it was higher in hamstring compared to the BTB at 6 years. Quad tendon is, I guess, one of the newer grafts that people have been doing, and this is my graft of choice. But only 11% of ACL reconstructions use the graft, because I think it's a little bit of a newer technique, and I think people have done BTB and hamstring for years, and they just kind of stuck with it. The benefits of a quad is that it's always predictable. I know exactly what I'm going to get. I know that I'm going to always have a 10 millimeter graft, which is not the case with BTB. especially with hamstring. Initial studies have not been good. Obviously, this is 40 years ago, and Frank Noyes showed that there's a you know 14.9% of graft strength compared to the other alternatives. And there were poor clinical studies early on. However, obviously things have changed. There's favorable results with BTB and free tendon techniques, and there's biomechanical studies that are supporting its use. If you compare it with the BTB, the cross-sectional area of quad tendon was twice than of the BTB graft. That's the thing where you always get something predictable out of this. It appears that biomechanically the load to failure and stiffness were higher with this graft. The outcomes are the same, however, functional outcomes and patient reported outcomes, however, you don't get the anterior knee pain with the quad. So again, there's the advantage there as well. As far as the hamstring goes, this is a study that demonstrated the superiority of the quad compared to the hamstring. There's a better results with KT 1000 testing, which tests laxity after surgery, and anything under 3 millimeters is acceptable. And here you can see that the hamstring was 3.1 millimeters, and then quad is 1.1. The donor side morbidity, there's with the quad harvest, there's a small incision on top. It's smaller than the BTB. Obviously, you don't cut the bone, or at least I don't with my quad harvest. But the big thing, with BTB is that you have that anterior knee pain, and it's difficult to kind of avoid that. But so BTB graft would not be good for like wrestlers or somebody that kneels a lot, and that sort of thing. Martial artists and that sort of thing. Hamstring, there's a risk of injury to the superficial branch of the saphenous nerve, which is the sensory nerve. The other thing with the hamstring is that the graft is not always predictable, and so when you're harvesting it, you kind of start with this, with the tendon that has a certain diameter, but then as you harvest it, sometimes you come up with a graft that is much smaller than you need, and so you have to use an allograft to reinforce that. And so that's for me, that is a big disadvantage of the hamstrings, that you don't really know what you're going to get until you actually harvest it. It's very difficult to predict it with the MRI. And then the quad tendon has quite infrequent morbidity. I think you cut the tendon, but there's plenty of tendon left over. I typically don't take the bone plug with it. People used to do that, where they take the sliver of the quad and then they take a part of the patella with it. I don't do it because I don't think it's necessary, and it avoids that anterior knee pain which you can get with that harvest. ACL repair is an option, although we have to be careful about this. I think you have to carefully choose patients who can be candidates for repair, and this is oftentimes when there's a clean avulsion off of the femoral aspect of the ACL insertion. Is a pretty recent injury. The patient is young and motivated, and so I think it's a good option in certain select patients. However, the cons are that there's no long-term results, and again, patient selection is kind of inconsistent. The new thing, the other thing that's beneficial about ACL repair is that if this repair fails, then you can always do a reconstruction. So that's, you're not losing much in the end, other than giving the patients 2 surgeries. And ACL repair is a shorter surgery. Bear trial is something that is new. It is essentially a repair, but then there's this collagen reinforced graft that is placed, that's going to sit in the gap between the tendon and the bone itself. And so what it does is this graft can hold the essentially blood and healing factors within that graft, and it will bridge that gap. And so, when you repair the ACL, there's a synovial fluid that floats, and then that prevents healing. Uh, Comparison wise, if somebody has an MCL tear, those heal non-operatively vast majority of the time because there's a lot of blood in the area and the healing factors can come in and they don't get washed out by synovial fluid. And so this is kind of what that looks like. You put the blood into this graft, you're kind of bringing over sutures and in the place where your repair is, and then that kind of allows for the healing to occur from the graft into the bone. And so then, we repaired the graft and now it's the post-op. In my opinion, extremely important part of rehab that some patients don't take it as seriously as they should. The rehab is long, as you always know, and it's 9 to 12 months and probably should be longer for adolescents. As far as the functional brace goes, there's not strong evidence to support using it. This study shows that there's no clinical difference at 1 and 2 year follow-up. However, some patients want it and some patients feel more secure with it, so I don't have a problem doing it for them. And so I typically offer it to patients at about 5-month mark once the quad has been built up to make sure that they get fitted and so on. And so the rehab is typically split into stages. The first stage is to regain the range of motion, and for me, very, very important to get the extension back, and then flexion. Closed door, open chain exercises. I think at this point, both work. I don't think there's a downside with appropriately monitored open chain exercises. That second phase where you're building the quad, that's important there. The last phase is obviously to work on jumping exercises and the mechanics of that area. Blood flow restriction therapy, we did quite a bit of this when I was in Colorado, and it does show that it can accelerate rehab for ACL reconstruction, and it strengthens the quad essentially better. So there's a higher extension strength in all these intervals. And so typically running, inline running, just slow jogging is about 4 months or so, but although this is very much patient individualized, we start getting them back into their sports-specific rehab at 6 months where, plyometric exercises and dynamic jumping exercises are introduced. And then for me, at least 9 months to a year for pivotal sports. And for adolescents, I'm even inclined to wait longer for that. It was and typically to get these patients back in, we do have to have some type of a assessment, and this is what my physical therapy colleagues do, and they're much more knowledgeable about this than me. But there needs to be, at least 90% symmetry compared to the other side, and strength and that sort of thing, until for them to be cleared to return to their usual sport. So that's kind of a quick and 30-minute kind of overview of this. I just wanted to make sure that we have time for people to ask questions and any other comments that they may have.
I just had a quick question about the functional bracing.
Yeah.
So I work with high school athletes primarily. So what are some of your pieces, or what are some of like your tricks in the conversations to kind of get people to understand that the brace is maybe not necessarily as important as they've thought it has been in the past?
Well, I think you work with high school athletes. For me, in that population, I would be a little bit, even though the data might not be that strong. However, the brace serves not just a stability purpose, in my opinion, it can also remind the patient, hey, this knee is not normal. You know, and I think sometimes it helps them condition the knee better and kind of get ready for whatever sport that they're gonna be doing. I typically give him the talk kind of like what I did now. This is, something that you can wear for a year or whatnot. It will give you some extra stability. I would say the objective results on a larger scale do not show clinical difference. However, if this is something that you feel would be beneficial for you, I am totally okay doing it. And I think, most people do agree to do it. Yeah. So, and again, it's not something that I discourage despite the evidence. Sometimes having that psychological breaking that psychological barrier after the ACL reconstruction is important to kind of get over it. So this is the other, we didn't talk about that at all, but like there's, definitely that part of rehab that people need to work on. I think if it gives them a little bit more security to be more free and to kind of get back to their usual, activities, that's why I don't mind doing it.
Awesome. Thank you.
Yeah, no problem. Any other questions? Well, if you have any questions, feel free to shoot me an email or shoot me a text or whatnot. I think here I can have a Matt kind of send that out to you guys or however, pretty easily approachable and happy to answer any questions after.
All right, well, I think we'll wrap it up then. I will follow up with everyone. I'll send out some of your contact information. So if you guys want to follow up with some questions afterwards, you're more than welcome. So I should send that information out this afternoon, but otherwise, thank you guys for joining us and hopefully we can do another one of these soon. Thanks.
Thank you.